Good morning, everyone, and thank you for this invitation, and thank you for being here. It's a great audience, and very hard to follow Ardem's talk. But what I will be talking today is about composing a cure for coma. Why do I say it is a composition? Because coma is a complex diagnosis, has different aspects that go beyond the norm of a clinical evaluation, pharmacological therapy, non-pharmacological therapy, and then genetics associated with it. So I think that effort requires a composition. And that's the reason we will try to understand how we can compose a cure for coma. Some of my disclosures. There you go. And our objectives is we'll try to define what coma is, what are the different components of coma, and what are the challenges we experience at bedside in providing a prognostication, and then what is the global effort we are developing in an effort to understand, address, and treat coma. All question starts at bedside. So before we go into this case, does everybody understand what a coma is? By show of hand, how many people know what coma is? Have heard about coma? It's a good number. So let's start with this case. 54-year-old person got brought to my ICU with a brain bleed. And this is the CAT scan. The CAT scan here shows that there is the white portions are the blood in the brain, that's in the left thalamus, and it's seeped into the ventricles, which are the fluid-containing cavities of the brain. It's caused by high blood pressure. 14 days into the ICU after treatment, the patient, eyes are closed, he groans to painful stimulation and to the extremities, and has withdrawal to pain, left side more than the right. The question here is he in a coma? By show of hand, how many of you think he's in coma? By a show of hand, how many of you think he's not in coma? That's interesting. So let's ask the question, so what is coma, right? To know that, we need to know the history of coma. If you look at the medical literature, the history of coma first goes back to ancestors of Dr. Varelas, who's here, from the ages of Hippocrates and Galen, from 500 BC to around 2 AD, where describe coma as a deep sleep. Okay? And then that concept remained the same as an irreversible sleep till about 1700s, where they started discussing about mechanistics of coma. Thomas Willis, Circle of Willis, as you all know, Nicolas Tulp, and then Bossier, Delacroix, they tried to understand what caused coma. Trauma, apoplexy, which is stroke, were the major etiologies of that time period. But how did they treat? Bloodletting, right? That was the treatment for most of the coma. It was not until the late 1900s or mid-1900s, Theodore Coker, Dejerine, Harvey Cushing started doing some surgical treatment, including trephinations, excavation of the mass lesions or space-occupying lesions, or decompression of the cerebrospinal fluid in an effort to treat coma and then make an impact on clinical outcomes. But what is the key aspect of coma? What are the anatomic correlates of arousal? As you know, arousal starts somewhere around the brainstem, in the upper brainstem, in an irregularly organized pathway around the aqueduct and then the fourth ventricle, called the ascending reticular activating system, where all these neuronal cells talk to the intralaminar nuclei of thalamus, and from there, they are broadcasted across the bilateral cerebral hemisphere cortices. So that is the anatomy of coma. And to do that, many cats have lost all their 9 lives, right? So they had to do specifically directed surgical lesions to understand how these cats would get into all different stages of coma. Soporific, sleepy, unresponsive, and then finally coma and brain death. So doing lesions in the medulla, W stands for all the spots where lesions were formed. In the rostral medulla, in the rostral pons, subthalamic area, and in the thalamus. All these lesions specifically targeted produced coma in cats. So we have established an anatomic correlate with a feline model. Let's go back to our patients. Now, what is the accepted definitions of coma that clinicians use? You have sleep anesthesia, there's no arousal, there's no awareness. There's a vegetative state where there is full arousal, but there is no awareness of your surroundings. And finally, minimally conscious state. There is full arousal, and there is partial awareness of your surroundings. And then there is locked-in syndrome, which is a different mechanism, where there is complete wakefulness, complete awareness, but the motor component is completely lost. If you have read the book, The Diving Bell and the Butterfly, where one of the fashion editors for the Vogue magazine experiences stroke in the basilar artery, most of their efferent responses are gone. And then he wrote a book just by blinking his eye. Every letter of the word represented an alphabet which was linked to a blinking. I would strongly urge you to read that book to understand what these patients go through. And then finally, there's normal consciousness, like who we are experiencing now, where we are completely aware, and then we are fully participatory with our environment. Let's take this definition and ask the question. Our patient has his eyes closed, but has motor responses. So is he in coma? Let's go back to the same poll. By the show of hand, how many of you think he's in coma? How many of you think he's not in coma? Okay, we are one step towards the right direction. So when we do a neurological exam, we go systematically. We look at alertness, cranial nerves, motor, sensory, coordination, language, and cognition, in increasing level of complexity. And one thing we forget to understand, that by assessing all these things, we are heavily dependent on the fact that these exams are limited by motor response. If you lack the motor response, this will be scored as not having any of those functions, right? So, what's going to happen to our patient? There are typically a few pathways or few clinical pathways patients take when they are in the ICU. You have an initial injury. You are sick for the first few days. You might end up in the vegetative state, or you might be actually having a cognitive motor dissociation where your ability to respond is impaired by your motor dysfunction. In that situation, you go to a minimally conscious state, go to a post-traumatic confusional state, also known as delirium, and then you go to recovery. So how do we decide which of our patients take one path or the other? What are the biomarkers? What are the imaging markers? And that is what we are interested in. Just to let you know, you don't need fancy techniques. You don't need functional MRIs. You don't need quantitative EEGs. You don't need funky testings to do that. This is a study where we looked at a sniff test. Has anybody ever driven their car behind a garbage truck in a slow traffic? Show of hands. How was that feeling? How did your breathing change? Imagine exposing your patients to an obnoxious smell. And this is what exactly happened here. What you do is, this is a sniff test. Sniff 1, sniff 2, baseline breathing, That's when obnoxious stimulus is induced, suddenly the amount of air intake is reduced because there is a process that is happening in the brain telling that there is an obnoxious smell coming in. So you take less amount of air. Simple bedside test, right? And when you do it on a significant amount of population, patients who were in minimally cognitive state, who ended up recovering better, had such responses for obnoxious smell. Obviously, that was statistically significant because I'm required to put blocks across the statistical significant areas. And then when you look at the sniff volumes and recovered versus unrecovered patients, pleasant smells in which the patients took deeper breaths as opposed to noxious smells when they did not take deeper breaths, both of them correlated with better eventual recovery of these patients. So, patients who have cognitive motor dissociation smell differently. They also see differently. What do I mean by that? When you look at pupillary responses, this is pretty much you open the eyes, shine a light into their eyes to see if the pupils are constricting or not. You see that there is a difference responses, and then you can actually ask questions for those patients. Show them a picture and say, is this your picture? Control, showing is actually their picture, and then a negative control showing somebody else's picture, and after that is the patient. And what you see here is that patients who had this cognitive motor dissociation had a different pupillary responses as automated by a pupillometer, right? You see here, the question yes and question no, the graph of the pupillary responses changed significantly. And then this continued over a period of time, and those patients who had variability in responses when they're shown with their photos as opposed to not their photos were the ones who actually ended up recovering well. So we do have a biomarker. The other thing is we start typically seeing our patients or rounding on our patients at around 6 in the morning, right? You go, shake them up, you open their eyes. How many of you have seen that the patients don't let their eyes open? Right? That is actually a great sign. Because in this particular study, they looked at patients who were not allowing to open their eyes and then quantified them. Not only did they do that, they put them through a functional MRI. And in the functional MRI, what they found was that the frontal areas, which are your executive areas that determine whether you are ready to embark on an activity or not, they lit up. So even a small bedside test has a imaging correlate showing that there is more higher cortical function present. And obviously, those are the patients who actually ended up having a better recovery. So this is another interesting study where a group of investigators looked at auditory startle response. What is a startle response? Everybody's seen kids, infants. If you clap in front of the infants, they have a startle response. And that is a brainstem response. In cerebral injuries, that is unmasked. So the higher cortical control is typically lost. And then so the more you clap, the persistent startle myoclonus, which I have a video I'll show you, continues. And those are the patients who are functioning at the brainstem level and then tend to have poor outcomes. What this particular study looked at was, will they extinguish that response? In other words, will the higher cortical controls take over the brainstem baseline activity and then put an inhibition to that? And looking at that particular study, the ones who were in minimal conscious state, which is in the right ones, had a higher proportion of being able to extinguish that startle responses. And then I'll show you this video of a patient who came to our unit. And this is how the startle response looked. Every time we clap, the person has myoclonic jerks not only in the face, but all over the body. So that is the baseline myoclonic response, and then that did not have an extinguishing on this patient. Now, if you map these electrical activities using obviously the EEG electrodes, and then you quantify the activities based on the number of hertz or number of waves you see per second, what you see is this nice, beautiful map, blue indicating less activity, yellow and red indicative more activity. So in patients who were able to extinguish that startle responses, they had more cortical activity, indicating that they have a higher cortical function, driving the brainstem responses down. So you do have a bedside test, right? And then finally, let me go back again, and mapping out with the functional MRI, the same areas, the medial frontal lobes that are involved in executive functions, were the ones that are active in such patients, and then this has turned out to be another biomarker to predict who will recover from coma, right? Another thing is, most of our comatose patients are on a ventilator, and then they have an endotracheal tube, or the breathing tube. And typically what we do is we check for cough responses, and they do is we shove a tube down there, we do a suction, and then they cough. This particular study was interesting because they looked at what is the heart rate variability, or what is the sympathetic response to a simple maneuver like suction. And what they found was very interesting. In patients who had an increased response of heart rate, or increased response of mean arterial pressures, those were the patients who were in minimally cognitive state, or those are the patients who ended up having better recovery eventually as they transitioned out into their subacute phase. And now we have talked about basic bedside testing. Now let's turn the heat up, go a little bit more into the diagnostic realm of quantifying EEGs. This is a study by Jan Claassen published in New England Journal. They identified patients who were in coma, and then they exposed those patients who did not respond. They were traditional definition of coma without motor response. And then they subjected to EEGs while they were given tasks. The tasks were, you speak to the patient like they were awake. You say, open your hand, open your hand, open your hand. Continuous commands for 3 minutes. Give a time period of rest. And then ask them to do the opposite, which is close your hand. And what they did was they found the baseline EEG activity using complex algorithm. They mapped out the change in the functions of the region of electrodes that you would anticipate the cerebral activity to act. And they compared with the controls. The yellow graphs here are the normally awake people who have higher activity. They can fire their neurons up to the normal. And the ones in blue are the ones who were in minimally cognitive state, who had similar activity as what we see in awake and alert individuals, but to a lesser extent. And obviously the patients who did not recover were in the black range, who were pretty much at the baseline. They did not show any major activity. So using this EEG algorithm, you can actually create a predictive model of which of our patients who are experiencing coma can have a better recovery. And then finally, let's turn the heat up a little bit more, right? When we look at the axis of coma, it's like peeling an onion, right? More layers you peel, the more complex it gets. You have a clinical phenotype. You have to establish that, following which you look at the structure, and that becomes your y-axis. And then throw in the functional components of it, that becomes the z-axis, and you look at addressing the arousal, volitional, and cognitive content using a mechanistic basis as a second-tiered approach once you establish these three. And finally, you overlay a period of time, because no patient in an ICU is the same within an hour. Things change. So within that time frame period, there are non-neurological things happening to the patients. There are extraneous influences. There are secondary neurological injuries that are creeping in. And that changes the way the patient works within that time frame of their recovery. So let's take a little bit more deeper look at that time frame of recovery. The structure, phenotype, function, and the patient is in all these different phases at any given point of time. There is no linear correlation with the time and how they behave. But defining each individual components will include not only the baseline function of the patient, what is the educational level of the patient, how were they functioning before they had neurological injury, but also on different cortices structures involved, and their, at the cellular level, what are the different challenges this patient is experiencing. So to unravel this, we need a large effort, and that is through Curing Coma. So what is Curing Coma campaign? Curing Coma campaign is a signature event by the Neurocritical Care Society, of which Dr. Varelas is the former immediate past president. Under his leadership, we have taken the audacious goal of addressing coma as a diagnosis. Till now, we have accepted coma as a byproduct of a neurological injury, but we will change it, and then our goal is to address coma as a principal diagnosis that affects the brain. And then it's the first global public health initiative to tackle, and then the unifying concept of coma as a treatable medical entity. And it does take a village to cure coma, and then this is my village. So we are launching a study called the COMPOSE study, where we are looking at acute coma recovery. And these are the sites, including Ecuador. Dr. Hibaja, who's in the audience here, his site will be one of our sites, will be enrolling patients into the study, looking at the natural history of recovery from coma, after which we will delve into the imaging, the diagnostic, therapeutics, and then hopefully even piezo involvement in coma recovery. Again, and this is my talk, and then in conclusion, what we can say is that standardized bedside neurological exam definitely provide insights into coma recovery. And obviously, the Curing Coma campaign is a big initiative launched, and then it's a worldwide effort to help researchers and diagnosticians and therapeuticians to come under single umbrella to help coma recovery. And then our COMPOSE study will be one of the first platform to launch that. Again, thank you so much for your attention, and I'll take questions.
You have a chance for questions. Yes.
Thank you, doctor, for your amazing speech. I'm Sebastián Colina. I'm a fifth-year medical student. Now I'm doing a rotation in the pediatric intensive care unit here in Quito. And I was amazed by this bedside test that you've done. And my question is how we can manage to do in a pediatric patient that has this reflex normally, but we can scare coma with the Glasgow scale, and they are only like 2 or 3 or even more. Like, how we manage to do this bedside test in a pediatric patient?
That's a great question. Kids are different animals, like I've always said. That's sorry, Kari. And they are very difficult to. And then if you look at the reflexes start and they get abolished. It depends on what age of the kid. You know, the startle response disappears by the first year of age, right? Startle should be gone by 1 year. If it's persistent, then it's pathologic at that point of time. So you need to tweak your neurological exam depending on the age of the child, and also substitute with it, because the smell response will not change. Smell response will be the same, whether it's a child or an adult, right? And then even there are pediatric intensivists who are working in the Curing Coma campaign, addressing some of the challenges you did mention. And then they are coming up with a white paper that is getting published within the next 3 to 4 months or so, addressing some of the questions you brought. But again, I'm not a pediatrician, but that's as much I know. Okay. Great question.
Anyone else?
Thank you very much for your talk. Maybe I missed it, but you mentioned about genetics, but I didn't see anything from genetics. Is there like a correlation between, I'm thinking metagenomics in different patients? Do you find that kind of thing?
There is a group from Mass General that is looking at epigenetics of stroke and stroke recovery, and then they are also trying to do the same for coma recovery. Again, this is still in the initiation phases. We're still discussing, and if that is something you're interested in, I would strongly ask you to just scan the QR code. That'll take you to the Curing Coma website. If you just put your name and information there, we can send all the connections and help you be a part of the process as well. But
Thank you very
good
much.
question.
Dr. Rao.